Jody Vance in for Mike Smith. We're going to talk about breast cancer here because there's a breakthrough that is stopping us in our tracks, really. First, some stats. I'm on the cancer.ca website looking up some stats in BC and in Canada, in fact. It's estimated that this year, in 2024, that 30,500 Canadian women will be diagnosed with breast cancer. This represents 25% of all new cancer cases in women this year. 5,500 Canadian women will die from breast cancer, 13% of all cancer deaths in women in 2024. So, on average, 84 Canadian women will be diagnosed with breast cancer every day. I'm sitting here thinking about the all too many friends who are in this fight big time. And the fear associated with a reoccurrence, because there's a great amount of technology to be had. There's preventative medicine in terms of mammograms and early detection and being a self-advocate, being aware of what's happening in your body and your breasts. And breast cancer can happen in men as well. It's rare, but it can happen. We lost our colleague Neil McRae to breast cancer. So anytime that you're checking yourself and advocating on your own behalf to your medical professional, it's really important, right? If you have been diagnosed with breast cancer and you knock it into remission, I've got a number of friends in that situation, they talk often about the stress associated with reoccurrence, which brings us to the news today, because there is a report of an ultra-sensitive new blood test that can predict if breast cancer will return years before the disease shows up on scans. This from researchers. I want to talk this through with somebody who knows much more about all of this than my everyday talking to my girlfriends who are in the midst of it all. Very pleased to welcome Dr. Paula Gordon, radiology researcher and clinical, I'm so excited to speak with you, Dr. Gordon. I'll get your title right. Radiology researcher and clinical professor at UBC. Dr. Paula Gordon joins us. Thank you for doing this, doctor.
Oh, you're very welcome, Jody. I'm so glad you're talking about it on the radio.
Well, let's have this conversation, because I immediately, when I found the article about this as it was breaking, I think it came up on one of my Apple feeds or what have you, and it was a BBC article, and read through it and immediately sent it to like 10 girlfriends. Oh my goodness. Like, what is this? What are we learning here? Because we really are at the forefront of breast cancer research in Canada, and in particular here in British Columbia, are we not?
Yes, and this is exciting, but rein it in a little bit because this is very preliminary. The study that
Okay.
was reported on was of only 78 women. And before you change policy and make tests widely available, you need a lot more research than that. These were all women who'd had breast cancer, who'd been treated with surgery and chemotherapy, and they were intensively studied with this highly sensitive blood test that looks for basically tumor DNA in the blood. I've been told it's like looking for a needle in a haystack. And there were 11 women out of the 78 who went on to develop metastatic breast cancer, and their test was positive in all 11 of them. But the cancer didn't actually show up. After the blood test was positive, sometimes for many months. In fact, the longest one that they followed was 41 months. So the hard part is, first of all, they cut off the study at 5 years. There were women who had a positive test who, at the end of 5 years, hadn't developed metastatic cancer. But it's possible that they developed it after the 5-year cutoff. So there might be false positives with the test. And second of
Which
all,
would
I
be
have
unnerving to say the least. Hold on.
Oh, yeah, but
Like
the
that.
question
That
is,
would, yeah.
even for the women who didn't have metastases for, let's call it 3 years, 36 months, are you going to start treating them when the blood test is abnormal, knowing that, first of all, they may have another 3 years before there's any evidence of disease? Or are you going to wait? Or is it possible that they're false positives and you shouldn't treat them at all? That's why it's too early to make this widely available. Yeah, it's extremely exciting research. It falls under the category of liquid biopsies, looking for cancer in various tissue fluids rather than have to biopsy them. So one of the questions is, well, what are we going to do? Are we just going to monitor these women more closely? The fact is, when the blood test is abnormal, it might be recurrence in the breast, but it could be there's nothing in the breast, but there's a focus of cancer spread somewhere else in her body, like the bones or
Mm-hmm.
the liver, right? And right now, after a woman's treated for breast cancer, she does not get routinely scanned. They don't do bone scans and liver scans and so on after a woman's had breast cancer. This study, the women had the blood test well, first of all, they had it even before their cancer was treated, and they had it after the treatment and every 3 months for the first year, and every 6 months up to the 5 years that they followed them. So, like I said, I mean, it's great that this is showing success, and there's been a desperate need for more research in better treatment for women who've had cancer. But we can't forget that what would be even better is, well, if we prevented it in the first place. Could we prevent women from even getting breast cancer? Can women modify their lifestyle to lower their risk to get breast cancer? And we know there's things women can do. They don't want to hear about them. They don't want to hear that they should be exercising regularly, decreasing, if not abstaining from alcohol, and so on. But we should also be working better on early detection of breast
Mm-hmm.
cancer. And we got a big fight ahead of us with the Canadian task force that I'm sure you heard about last week. So
We
I
did.
don't want to.
Sorry, just let me tell people who, just in case you just tuned in, we're speaking with Dr. Paula Gordon, radiology researcher and clinical professor at UBC. We're talking about breast cancer, and this, the jumping off point being this ultra sensitive blood test. But Dr. Gordon, you've said it's kind of like a needle in a haystack situation. It's a good step forward research wise, but far from being available broadly because this testing is so small, so limited at this point, but certainly a positive research moving forward. But let's talk about the struggles that are ahead and how early detection can be very confusing, what women should and should not do, and breast density and how that comes into play. It's very complex and daunting for women of a certain age who are, finding in their friend group that many of us are being diagnosed with breast cancer and wishing we had known what to do sooner, or the things that we could do, as you say, preventatively.
Well, and unfortunately, it's not just confusing for women; it's confusing for family doctors because they're getting information from this Canadian task force, which is made out to be a panel of experts. But in fact, they're not. They're not breast cancer experts. They actually exclude experts from their guidelines panels, and they're making recommendations that go to all the family doctors in Canada. The head of the task force is a family doctor, and there are other family doctors and other non-breast cancer specialists making guidelines for breast cancer screening. I'll make it really easy for your listeners. And women in
Thank you.
BC have it especially lucky because in British Columbia, women can self-refer. They don't need a requisition from their doctor. They can self-refer for mammograms starting at age 40. And I highly recommend that. Experts highly recommend that.
Yes.
Other thing that we're lucky about in BC is that women are told on their screening mammogram report what their breast density is. And just for people who haven't heard the term, breast density refers to the ratio in the breast of glandular tissue or breast glands to fat. All breasts have glands and fat in them, but it's the proportion that varies from one woman to another. In British Columbia, starting in late 2018, women's mammogram report, the one they get in the mail after they've had a routine screening mammogram, tells them what their breast density category is, A, B, C, or D. A and B are not dense. Categories C and D are dense. And women who have dense breasts have two risks. The most important risk is that if they do get cancer, It might not be visible on their mammogram. We call that masking because cancer, which is white on a mammogram, can hide in the normal dense breast tissue, which is also white, looking for a snowball in a snowstorm. But the other
Mm,
risk is that women with dense breasts are at a higher risk to get breast cancer than women with non-dense breasts. So in BC, first of all, go for screening starting at
yep.
40. And you don't even have to ask your doctor. Second of all, find out what your breast density is. If you find out that it's dense, you can get supplemental breast ultrasound screening. So ultrasound finding many of the cancers that are missed on mammograms. But that's where it gets hard because there aren't enough clinics yet offering the test. And we're working very hard to make it something that clinics across British Columbia will offer, because we are finding those cancers that are missed on the mammograms. And if you can't get a breast ultrasound, for heaven's sakes, do breast self-exam, get to know what your normal lumpiness feels like, so that if there's a change and there's a lump starting to develop, you'll find it as early as possible. So that's cutting to the
Doctor,
chase.
yeah, no, I love it. It's all great information. Someone with that C density. You're teaching me. I definitely go for my mammogram quickly here. I'm short on time and long on questions. Why is the task force not consisting of breast specialists, breast cancer specialists? Why are the directives to GPs coming from people who don't understand in depth what women need when it comes to preemptive testing? Like, why wouldn't we all get mammograms starting at 40? I guess cutting to the chase. Why wouldn't we?
There's a long list of why the task force didn't recommend screening at 40, but primarily because they're not experts, and they don't understand the nuances. What they did was basically rely on, I hope you're sitting down, they're relying on studies that were done 40 to 60 years ago
Oh,
and
please.
not on the more recent research that's been done. And that now we get into the technicality of what kind of research it was. The older trials
Right.
were called randomized control trials, and they
Yeah.
proved that mammograms save lives. The newer studies are called observational studies, so they don't have a control group. And people say, well, then why don't you just do another randomized trial? It would be unethical to do a randomized trial in this day and age, now that we've proven that mammograms save lives. You cannot have a control group that's not having mammograms.
Right. And
And
let's be
so,
clear, mammograms are quick, easy, painless, and preventative.
well,
I mean,
uh, they're not painless, and women need to know that. Yes, they are uncomfortable. And there are
well,
women with really,
uncomfortable, but not painful.
there are some women whose breasts are so sensitive that that compression is very uncomfortable, but it's only for a few seconds. And
Right.
women need to know that it's okay to tell the technologist who's doing the exam on you, that's as much as I can take. Please don't put on any more compression.
Oh,
It's
there you
okay
go.
to do
That's a good
that.
one.
And I'd
Okay.
rather a woman has a mammogram with slightly less compression than to not show up again next year because it hurt too much.
Right. Absolutely. Bang on. But Dr. Gordon, thank you for giving us some of your time today. I really appreciate it.
My pleasure. Take